Yeah, so I think we're already doing that, and of course for the younger patients, the backbone remains intensive chemotherapy and the stem cell transplant. With that said, the data that we're shown here, for example, for the combination of high-dose chemotherapy and venetoclax, they look very attractive, with very high response rate over 85% and high rates of MRD negativity. So I personally believe that this will be the future for younger patients to get very deep remissions and get them towards stem cell transplantation. The older population is much more challenging, and that's where we are trying to use what we call personalized medicine. In the younger too, but perhaps not to the same extent. And that's where we're going generally by mutational profiling, right? So I think there's a lot of data that if we wait for specific mutations and some of the cytogenetic data, we can personalize therapy. So the examples again is, FLT3 mutated patients, they tend to have high white count, they're very proliferative. And I think it makes sense to wait for the results because we can use the same, let's say triplet, AZA-VEN triplet, that is very effective and safe. If they have IDH1/2 mutation, we know we have a lot of options. So we have HMA-VEN, which works fairly well, but perhaps not curative. We have azacitidine, which is IDH1 inhibitor that's shown to have very good overall survival data, about 24 months with the newly diagnosed IDH1 mutated AML. And then now we can maybe consider using triplet, but triplets are only in the setting of clinical trial. Now, if the patient has P50 mutated disease, we don't have many options, unfortunately. We know that venetoclax does not add to the hypomethylating agents, and we know that these patients are very hard to cure. So this is where we would generally recommend clinical trial, if there is one, with immune therapy or some other options. But in practical life, physicians generally just using hypomethylating agents and trying to get them to the stem cell transplantation. So I think that's on the level of genetics, but there's also like next level of the what we call fitness, right? How well the patient can even tolerate AZA-VEN, right? Because AZA-VEN is not really like low intensity therapy. It is more or less, fairly intensive, especially first cycle. So that's where there's a lot of discussion whether giving them 21 or 28 days venetoclax is really makes sense, or maybe we don't need as much venetoclax, right? There's data with 7+7, AZA-VEN is 7 days each. In our center, we are trying weekly regimens, so very low intensity regimens, which seems to work slower, but as effective. So that's another coil you have to look at. So people who cannot even tolerate the HMA-VEN backbone, whether we can reduce intensity and still get them a good quality of life response and some duration of response.